Identifying fluid imbalances. Fluid deficit signs would include weight loss, increased 30 pulse rate, diminished blood pressure, commonly with orthostatic hypotension, decreased CBP or central venous pressure, sunken eyes, dry conjunctiva, decreased hearing, poor skin turgor. But remember, this may not be a reliable sign in elderly patients. Pale, cool skin, poor capillary refills, lack of moisture in the groin and axillary area, thirst, decreased salivation, dry mouth, dry, cracked lips, and furrows in the tongue. Signs of fluid deficit to be continued. They may have difficulty forming words, mental status changes, weaknesses, diminished urine output, increased hematocrit, increased serum electrolyte levels, increased BUN levels, and increased serum osmolarity levels. Now remember, patients may need to moisten their mouth first if they're having difficulty forming their words. On the opposite end of the spectrum, we will be discussing signs and symptoms of fluid excess. Weight gain, elevated blood pressure, bounding pulse, JVD or jugular vein distension, increased respiratory rate, dyspnea, moist crackles or rhonchi on auscultation, generalized edema. Edema in dependent body parts, so sacral area for bed rest patients. And for patients that are ambulatory, lower extremity, puffy islets, periorbital edema, decreased hematocrit, decreased serum electrolyte levels, decreased BUN levels, and decreased serum osmolarity levels as well. In calculating flow rates, the volume of infusion in mLs is divided by the time of infusion in minutes, multiplied by the drop factor. Drops per ml is equal to the flow rate in drops per minute. For example, listed below, the drops per minute, which is the flow rate, equals out to be the volume in mLs times the drop factor, divided by the time in minutes. For practice, you have an order to administer 1,000 mLs of normal saline over 2 hours. The drip set contains 60 drops per ml. What is the answer? The drop per minute equals out to be 1,000 mLs times 60. Hours was 2 hours times 60, which is 120. So therefore, you would divide 60,000 by 120. Therefore, your answer is 500 drops per minute. As for UMC specifics, document date, time of insertion, location on dressing, and in electronic record or on paper if not fully automated. Evaluate and document at least every 4 hours. Skin integrity, signs of infection, infiltration, and mobility limitations. Make sure that we are changing our peripheral sites and tubing and caps every 96 hours. And document any rationale if not possibly done. As for the pediatric population, peripheral sites will be changed with signs of infection or if the IV is not functioning. Occlusive dressing will only be viewed every 24 hours unless problematic. The rapid response team will be contacted if unable to obtain access after 2 attempts. According to the vascular access policy, patient care 42.5, and the intravenous therapy policy, medication administration 302. As for peripherally inserted central catheters, also known as PICC lines, these are inserted into the basilic cephalic vein just above or below the antecubital space of the right arm. The tip of the catheter rests in the superior vena cava, and these are for long-term IV access. Rapid response team will be notified for PICC assessment and placement if PICC certified is not available. Only trained providers or RNs who have successfully completed a formal PICC class with demonstrated competency in insertion, which usually is 3 initials and 3 annually, and maintenance will place PICC lines. PICC lines to be concluded. Physician order is needed to place the PICC line. A consent is obtained by the performing nurse. A chest x-ray to confirm tip location. After the chest x-ray confirmation of proper placement is made, there should be no further manipulation. PICC lines may be removed by any licensed nurse. External jugular IV insertion, also known as EJs, are used for short-term access when peripheral access cannot be obtained. A physician order is required for insertion, and a plan for immediate alternate, unless needed for less than 24 hours, should be made. Nurses must have appropriate training with documented TPP addendums to insert EJ catheters. Any nurse must discontinue EJs using the same technique as a peripheral IV. Emergency center charge nurses and rapid response nurses are the only staff approved for this competency, according to the Vascular Access Policy, Patient Care 42.5.